I want you to imagine, just for a second, an invisible hammock of muscle and connective tissue, just suspended right there at the base of the pelvis.
Right, it's this incredibly complex biomechanical structure.
Yeah, exactly. And it's managing constant intra-abdominal pressure, urinary control, bowel control, and, your core stability. But when things go wrong there, when that structural integrity fails, you get pelvic floor dysfunction, or PFD.
Which is surprisingly common.
Extremely. It impacts roughly 1 in 3 women, and the resulting conditions like stress urinary incontinence or severe pain during sex, which is called dyspareunia, they just drastically alter a patient's baseline quality of life.
Yeah, they really do.
Yeah.
And historically, the clinical pathways for managing PFD have presented this really frustrating dichotomy for patients.
Like you're stuck between a rock and a hard place.
Exactly. Patients are either steered toward conservative management, which means months of grueling behavioral and physical adaptations, or, they escalate right to invasive surgical intervention.
Right, like sling procedures.
Yeah, and those introduce a whole host of perioperative risks and long-term complications.
So today's deep dive explores a rapidly evolving intersection in modern gynecology that really challenges that dichotomy. We are analyzing the intense, frankly sweat-inducing protocols of pelvic floor physical therapy and how they're going head-to-head and ultimately joining forces with cutting-edge vaginal laser technologies.
It is a fascinating shift in the field.
It really is. And we are synthesizing a dense stack of sources today for you. We've got specialized clinical trials, official guidelines from Z in the UK, FDA safety communications, and some highly detailed real-world clinic protocols.
So we're really getting into the weeds on the cellular mechanisms here.
We are. Our mission is to dissect those mechanisms and understand how these totally distinct modalities are being combined in simultaneous uptraining protocols. Okay, let's unpack this. Before we get into energy-based devices and photobiomodulation, we need to establish the baseline of the current gold standard.
Which is physical therapy.
Right, because true, clinically supervised pelvic floor physical therapy requires a level of neuromuscular re-education that goes way beyond, the casual Kegel exercises most people are familiar with.
Oh, absolutely. The clinical trials we are evaluating, particularly the protocol designed by Condi Rangel and colleagues, they really demonstrate the sheer physiological demand of these regimens.
It's not just squeezing a few times while you're at a stoplight.
Not at all. A proper clinical assessment doesn't even rely on self-reporting. A physiotherapist utilizes what's called the Modified Oxford Grading System.
Okay, what is that exactly?
It's a 0 to 5 scale.
Yep.
And they assess the patient via digital vaginal palpation to measure the baseline strength, the endurance, and the actual lift of a voluntary muscle contraction.
And a score of 0 on that scale, that indicates complete akinesia, right?
Yes. The muscle is entirely unresponsive to voluntary commands from the central nervous system.
Wow, so you can't even tell a patient with a grade 0 to just start doing resistance training because that neuromuscular pathway is effectively just offline.
Exactly. They can't do the exercise even if they want to. So the Condi Rangel protocol addresses this by initiating treatment with intravaginal electrical stimulation, or IES.
Electrical stimulation, that sounds intense.
It is very targeted. They apply a 50 hertz high-frequency stimulation, and this specific frequency, it's optimal for depolarizing the motor nerve fibers.
So it's essentially forcing a contraction.
Yeah, basically. It forces the contraction and sends this strong afferent feedback up to the somatosensory cortex in the brain. The whole goal is to bridge that neurological gap.
Using the electrical current to sort of wake up the brain-muscle connection.
Right, until the patient can achieve at least a grade 1 on the Oxford scale, which just indicates a tiny flicker of voluntary movement.
Okay, so once that baseline voluntary control is finally established, then the endurance conditioning begins. And looking at the protocol, it mandates 12 weeks of training, twice weekly, under strict supervision.
Yes, and the physical endurance required is staggering.
I mean, a patient is tasked with executing a sustained maximum isometric contraction and holding it for 8 full seconds.
Right, which is a long time for that muscle.
Yeah, and then they rest for only 6 seconds and immediately transition into 4 rapid-fire phasic contractions. And the biomechanical load is constantly shifting, too.
Yeah, the posture changes are a huge part of it.
They perform these sequences supine with knees bent, then supine with legs straight, then in a lateral position on all fours, sitting, and finally standing.
And those postural transitions are non-negotiable. The pelvic floor musculature, it must continuously adapt to shifting vectors of gravity and, varying levels of intra-abdominal pressure during daily activities.
Because life doesn't happen lying down.
Exactly. Training exclusively in a supine position fails to prepare the pelvic floor for the dynamic loads of, like, walking or lifting groceries.
So it's essentially this elite Olympic weightlifting program engineered for an invisible internal muscle group.
That's a great way to put it.
But so, if this is the gold standard, why look for alternatives? Is it just because 12 weeks of intense posture-shifting exercises is too hard for patients to stick with? I mean, are clinicians merely trying to circumvent the high attrition rates, or is there a fundamental physiological ceiling to what physical therapy can achieve on its own?
If we connect this to the bigger picture, muscle hypertrophy only addresses one half of the structural equation,
Okay, what's the other half?
connective tissue. Muscles require this robust connective scaffolding, specifically fascia and ligaments that are rich in collagen and elastin, to actually generate effective tension.
Oh, I see.
So physical therapy can strengthen the levator antimuscles, sure, but it cannot synthesize new collagen to repair degraded fascia.
Ah, so the underlying architecture itself is compromised.
Exactly.
Because through natural aging, mechanical trauma from childbirth, and the systemic withdrawal of estrogen during perimenopause and menopause, the vaginal tissue undergoes massive atrophy. The mucosa thins out, the extracellular matrix loses its elasticity, and the local vascularity just plummets.
Right. And you can build maximum muscle tone, but if those fascial anchor points are severely attenuated, the structural collapse will just persist.
Whether that presents as prolapse or incontinence.
Right. So clinicians realized they needed a localized intervention to actively remodel that connective tissue matrix.
And that specific clinical gap is what drove the rapid adoption of transvaginal energy-based devices, right? Especially for patients presenting with genitourinary syndrome of menopause, or GSM.
Yes. And our sources emphasize a critical technological distinction here between ablative and non-ablative lasers.
Okay, let's break that down.
So ablative devices, which are primarily fractional CO2 lasers, they operate by inducing controlled thermal necrosis.
Thermal necrosis, so they are essentially burning the tissue.
Basically, yeah. They vaporize microscopic columns of the vaginal mucosa, and the local tissue responds to these microinjuries by triggering an acute inflammatory cascade.
Rushing cytokines and fibroblasts and blood flow to the site to drive reepithelialization and build new collagen. But the mechanism of the non-ablative erbium YAG laser, which operates at a 2940 nanometer wavelength, is entirely different.
Completely different, yeah.
It does not vaporize tissue or rely on thermal injury at all. Instead, it utilizes photobiomodulation, or PBM, delivering near-infrared light to actually manipulate cellular respiration. Here's where it gets really interesting. Because the target of this near-infrared light is a specific chromophore located inside the mitochondrial electron transport chain.
Right, cytochrome C oxidase.
Yes.
And to appreciate the impact of targeting cytochrome C oxidase, we have to look at the cellular environment of atrophic or hypoxic tissue.
Tissue that's starving for oxygen.
Right. Under conditions of oxidative stress, nitric oxide acts as a competitive inhibitor. It binds to the cytochrome C oxidase receptor and effectively blocks oxygen from binding.
It's like a squatter refusing to leave the cell's power plant.
Exactly. And that halts the electron transport chain, which severely depresses the synthesis of ATP, which is the primary energy currency of the cell.
But the near-infrared light from the YAG laser operates at the exact absorption spectrum required to photodissociate that nitric oxide molecule, right?
Yes, it physically detaches the nitric oxide from the receptor.
It kicks the squatter out.
Exactly, which allows oxygen to rush back in, restarting the electron transport chain and basically flooding the cell with newly synthesized ATP.
Wow. And the secondary effects of that dissociation are equally wild for tissue regeneration, because that displaced nitric oxide doesn't just disappear. It diffuses into the surrounding extracellular space, where it acts as a really potent vasodilator.
Right. It relaxes the smooth muscle lining the local blood vessels and drastically upregulates microcirculation.
More blood flow, more healing. And concurrently, the photobiomodulation modulates the activity of the cyclooxygenase enzyme, which leads to a marked decrease in the synthesis of prostaglandin E2.
Which is huge for pain management.
Right. Lowering prostaglandin E2 directly suppresses the localized inflammatory response and nociceptor activation, meaning the treatment actively downregulates pain pathways at the molecular level.
And this incredible biochemical cascade translates into a highly streamlined clinical protocol.
Yeah, we're talking 3 outpatient sessions spaced 4 to 6 weeks apart. They take maybe 3 to 7 minutes, require 0 anesthesia, and boast an immediate return to normal activities.
The immediate appeal of that protocol is just undeniable.
Hmm.
The capacity to restore cellular energy production, induce vasodilation, and mitigate pain without surgery or months of physical training. I mean, it represents a massive paradigm shift.
I do have to challenge the overarching narrative here, though.
Go for it.
Wait, is this just a fancy, expensive heat lamp? How do we know it's not a placebo effect? The physiological mechanism sounds pristine in a controlled laboratory, sure. But anytime a non-invasive, highly lucrative technology rapidly permeates clinics without decades of longitudinal data, the potential for placebo-driven results or unforeseen complications is massive. We are essentially relying on invisible light to reverse complex biomechanical failures.
And you're not the only one asking that. That underlying skepticism is exactly what triggered a severe regulatory backlash.
Right, the 2018 FDA warning.
Yes. In 2018, the FDA issued a very forceful safety communication warning against the use of these energy-based devices for what they broadly termed vaginal rejuvenation.
The agency cited adverse event reports detailing severe complications like vaginal burns, extensive scarring, and exacerbated dyspareunia resulting from tissue damage.
Yeah, the intervention of the FDA forced a massive recalibration in the whole field.
But analyzing the sources, particularly the responses from major urogynecological societies, it reveals a fierce debate over the FDA's terminology and their methodology.
Oh, definitely. The core argument from researchers like Guo and colleagues is that the FDA improperly conflated elective, unregulated cosmetic procedures with targeted medical therapy.
Right, lumping cosmetic stuff marketed as rejuvenation and with treatments for diagnosed pathologies like severe GSM and stress urinary incontinence.
The distinction in clinical intent is paramount there. When researchers conducted a retrospective analysis of the FDA's own MAIU database, Oluwoli's review actually quantified the real risk.
And what did they find?
Out of hundreds of thousands of procedures performed globally, they isolated only 45 individual records of severe complications.
Wow. I mean, obviously, 45 cases of scarring and burns are clinically significant for those individuals. We aren't minimizing that. But framing that against a denominator of hundreds of thousands of treatments, that yields an exceptionally low complication rate.
It does. It suggests the adverse events were likely driven by improper device calibration in those cosmetic settings rather than an inherent flaw in the photobiomodulation mechanism itself.
So to bypass the regulatory noise, we have to look strictly at the controlled clinical data.
And what's fascinating here is how the clinical trials actively separate the subjective marketing claims from objective anatomical outcomes.
Let's look at the head-to-head pilot trial. The one comparing women with stress urinary incontinence who either got 3 sessions of the non-ablative ERYA laser or 3 months of rigorous, supervised pelvic floor physical therapy.
Right. They randomized 40 women. And the data indicates that both cohorts achieved statistically significant improvements on the Oxford Grading Scale.
And across their standardized quality of life questionnaires, too, both groups improved.
Yeah. The photobiomodulation protocols held parity with the established gold standard of neuromuscular training in managing SUI symptoms.
Which is incredible. But moving from smaller pilot trials to larger prospective studies gives us a higher resolution on the actual anatomical changes, like the comprehensive study tracking 163 women treated with the non-ablative laser.
Right. They utilized the pelvic organ prolapse quantification system, or POPQ.
And that system relies on precise measurements between anatomical landmarks during a Valsalva maneuver, right?
Yeah.
To grade the severity of prolapse and structural laxity.
Exactly.
So if the non-ablative laser is successfully remodeling the connective scaffolding and increasing collagen density, I'd expect to see objective reductions in those POPQ measurements. But does repairing the extracellular matrix actually translate into improved subjective sexual function for the patient, given the intricate symbological and neurobiological factors involved?
The data reveals exactly that tension between anatomy and subjective experience. The POPQ assessments demonstrated objective, modest structural improvements.
Okay, so the anatomy got better.
Yes. The measurement of the vaginal hiatus, which is the anterior-posterior dimension of the pelvic opening under pressure, it decreased significantly. And patients exhibited a shift toward less severe prolapse staging.
But what about the subjective experience?
Well, when researchers evaluated overall sexual function utilizing the Female Sexual Function Index, or SFI, The aggregate scores remained relatively static.
Ah, so the laser therapy successfully repaired the structural integrity of the fascial hammock, but it did not serve as a panacea for complex sexual dysfunction.
Right. The physiological remodeling doesn't automatically overwrite the psychological or neurobiological components of sexual health.
But ironically, the fact that the anatomical data improved while the FSFI scores remained stable, that actually lends credibility to the mechanism, doesn't it? It confirms the treatment is driving real structural change rather than merely generating a massive placebo effect.
It absolutely does. And the clinical consensus emerging from the major medical societies really reflects this nuanced data. The recommendation is to proceed with these devices for targeted medical indications, strictly avoiding the cosmetic rejuvenation marketing.
And ensuring patients understand they are receiving a structural intervention, not a global cure for complex sexual function.
Exactly.
Are we letting the murky, unregulated cosmetic side of this technology ruin access to a legitimate medical treatment for women suffering from chronic pain and incontinence? Seems like it was a close call there.
It really was.
So we have established that intense physical therapy effectively induces muscle hypertrophy, and non-ablative laser therapy successfully remodels the connective tissue matrix while boosting local cellular energy. But what if the optimal clinical pathway isn't a choice between energy devices and physical therapy?
Oh, this is the best part.
What if the true frontier of pelvic medicine is the precise synchronization of these two modalities to exploit their overlapping biochemical effects?
The latest research is aggressively pursuing that synthesis. Studies spearheaded by DeMarchi, De Silva, and their teams, they demonstrated that applying transvaginal photobiomodulation independently enhances resting pelvic muscle tone.
Just the light alone does that.
Yes. But more importantly, the tissue remodeling and vasodilation effectively prime the neuromuscular environment, rendering the levator ani muscles significantly more responsive to subsequent physical training.
Which brings us to the highly complex case series developed by Hosseinzad and colleagues. They designed a simultaneous up-training regimen for menopausal women suffering from stress urinary incontinence.
And they aren't just stacking the treatments sequentially.
No, they are executing a synchronized clinical protocol utilizing concurrent transvaginal and intrabladder low-level laser therapy.
The spatial mapping of their protocol is incredibly aggressive.
Walk us through it.
The procedure initiates with the insertion of a specialized laser fiber through a urethral catheter directly into the bladder, irradiating the bladder fascia from the internal mucosa.
Okay, wow. And following that intrabladder phase, they transition to transvaginal irradiation. They deploy a 360-degree vaginal probe emitting at 630 and 780 nanometers to target the superficial mucosa.
Right, and then they follow that with a concentrated 808 nanometer wavelength for the final 5 minutes to penetrate the deeper fascial layers.
But the defining variable of the Hosseinzad protocol occurs during that exact final 5-minute window. The patient is not resting passively while that 808 nanometer laser fires.
Not at all. The clinicians instruct the patient to execute a high-intensity physical therapy sequence precisely while the tissue is actively absorbing the near-infrared radiation.
They are flexing while the laser is firing.
Yes. The patient must perform 10 consecutive isometric contractions, holding maximum tension for 6 seconds, followed by 6 seconds of rest, completing multiple sets while the laser actively floods the target tissue.
It's the biological equivalent of attempting to rebuild a car's transmission while the engine is running at 4,000 RPM.
That's exactly what it is.
So, what does this all mean? Does the influx of ATP and nitric oxide from the laser literally give the muscles the fuel they need to complete the grueling PT protocol we talked about in the beginning?
The synergistic data strongly supports that hypothesis. By firing the near-infrared laser during active muscular contraction, the protocol ensures maximum oxygen delivery and ATP availability exactly when the metabolic demand of the muscle tissue peaks.
That makes so much sense.
And simultaneously, the laser-induced suppression of prostaglandin E2 ensures the patient isn't fighting through acute localized inflammation or pain while holding those 6-second contractions.
The photobiomodulation basically clears the biochemical pathway, allowing the physical therapy to subject the newly energized tissue to maximum biomechanical stress.
Yes, and the intervention seamlessly transitions from the clinic right to the patient's daily routine.
Right, because following the simultaneous laser plus flex sessions, the protocol dictates a rigorous home maintenance phase. Patients are prescribed 10 to 20 precise pelvic floor exercises to be executed twice weekly.
The energy-based device provides the acute cellular remodeling and the biochemical surge necessary to overcome that initial compliance hurdle.
But the long-term structural integrity still relies entirely on the patient maintaining that neuromuscular tension through disciplined physical therapy.
Exactly. It represents a fundamental evolution in how we approach pelvic floor rehabilitation.
Mhm.
The field is moving away from treating the levator ani muscles in total isolation and toward a really comprehensive biomechanical model.
Clinicians are manipulating the cellular respiratory cycle at the mitochondrial level to directly facilitate macroscopic muscle hypertrophy and fascial repair. It's wild.
It is.
To synthesize the ground we've covered today for you all, we examined the severe biomechanical demands of traditional pelvic floor physical therapy. We detailed the 12-week regimens, the 50 hertz electrical stimulation required to wake up neural pathways, and the relentless postural adaptations.
And we analyze the complex photobiomodulation mechanisms of non-ablative lasers.
Observing how targeting cytochrome sigma oxidase with near-infrared light evicts nitric oxide, spikes ATP production, and triggers neocollagenesis. And ultimately, we explored the frontier of combined uptraining protocols, where clinicians simultaneously flood the tissue with laser energy at the exact millisecond the patient executes a sustained muscle contraction, fusing biochemical remodeling with mechanical hypertrophy.
The rapid progression of these concurrent protocols really underscores the necessity of moving past the initial regulatory controversies and focusing on the rigorous objective data mapping these cellular interactions.
Absolutely. And I want to leave you with a final concept to mull over that extends the logic of everything we've dissected today. We have detailed how targeted photobiomodulation manipulates nitric oxide and ATP to render the pelvic musculature immediately and profoundly more responsive to acute physical stress.
Right.
Could this exact concurrent laser plus flex methodology be adapted to overcome the biological limits of other complex muscular rehabilitation?
Oh, applying synchronized photobiomodulation to broader neuromuscular deficits presents a massive opportunity for future clinical trials.
Consider the implications. Could the future standard of care for physical rehabilitation, whether addressing severe ligament trauma in the knee or attempting to rebuild motor pathways following a stroke, could it involve irradiating the compromised tissue with specific near-infrared wavelengths at the exact moment the patient attempts a voluntary contraction?
It's a huge question.
If manipulating the mitochondrial transport chain allows us to successfully rebuild the invisible hammock of the pelvic floor, the potential applications for structural rehabilitation across the rest of the human body are virtually limitless.